We'll discuss infective endocarditis. Infective endocarditis is an infection of the heart's inner lining, or endocardium, that usually involves one or more heart valves. The endocardium is biologically similar to the endothelial lining of blood vessels and is normally resistant to infection by bacteria and other organisms. Most cases of infective endocarditis develop following damage to the endocardium. This results in activation of endocardial cells, triggering a prothrombotic state that causes focal adherence of platelets and fibrin. When bacteria enter the bloodstream, this platelet-fibrin layer acts as a foothold, allowing the organisms to adhere to the endocardial surface. Bacterial proliferation leads to recruitment of leukocytes and further cycles of platelet-fibrin accumulation. Local release of cytokines also results in increased deposition of extracellular matrix components such as fibronectin. The end result of this process is the formation of macroscopic vegetations consisting of platelets, leukocytes, and interspersed clusters of bacteria encapsulated within a fibrin and fibronectin meshwork. Bacteria deep within the vegetation are protected from the immune system by the matrix of cells and scaffold proteins, and they also exhibit reduced metabolic activity that can lower the effectiveness of certain antibiotics. As the vegetation grows, bacteria can infiltrate the underlying tissue, potentially leading to destruction of the valve. The vegetations also have poor structural cohesion, which allows fragments to break off and embolize within the bloodstream. Vegetations usually affect the left side of the heart, with the mitral valve being involved somewhat more frequently than the aortic valve. This is due in part to the higher pressures in the left heart, which can induce endocardial injury more easily. Vegetations involving the right side of the heart are significantly less common and predominantly affect the tricuspid valve. Involvement of both sides of the heart can also occur in a minority of cases. The risk factors for infective endocarditis include conditions that predispose to endocardial damage or facilitate bacteremia. Pre-existing structural heart disease can lead to continuous endocardial injury due to regurgent blood flow or high-pressure jetting of blood through stenotic regions. Poor dentition or dental infection also increases the risk, as this facilitates entry of oral bacteria into the bloodstream. Prosthetic heart valves are associated with a high risk of infective endocarditis, as the foreign material is more conducive to infection than native valves. Intravascular devices such as central lines or pacemaker leads can also become infected and have the potential to damage the endocardium. Intravenous drug use is another significant risk factor because it can introduce particulate matter into the circulation, causing valvular injury. Lack of sterile technique can also allow skin flora direct access to the bloodstream. Specific risk factors such as intravenous drug use and the presence of intravascular devices are strongly associated with right-sided endocarditis. A number of pathogens can cause infective endocarditis. Gram-positive bacteria adhere more readily to the endocardium compared to gram-negative bacteria, and are the most commonly implicated organisms. Staphylococcus aureus is the most frequently isolated pathogen. This bacterium has particularly high virulence and can infect previously undamaged valves, unlike other organisms. Viridans group Streptococci are also frequently identified. These bacteria are normally present in the oral cavity and can be seeded into the bloodstream during dental procedures. Enterococci are part of the normal intestinal flora and can cause endocarditis in susceptible individuals following genitourinary procedures or gastrointestinal surgery. Streptococcus bovis is also normally found in the gastrointestinal tract and has a predilection for causing endocarditis in patients with colorectal malignancy or inflammatory bowel disease. Coagulase-negative staphylococci are commensal organisms found on the skin and mucous membranes. These bacteria produce a biofilm on foreign material and are often associated with endocarditis in patients with prosthetic heart valves or intravascular catheters. Non-bacterial causes of infective endocarditis include fungi such as Candida and Aspergillus. Although relatively rare, this form of endocarditis is associated with a particularly poor prognosis. Infective endocarditis can vary in acuity and severity. Some patients develop a rapidly progressive infection with signs of obvious cardiac involvement, while others have a more subacute or chronic course with relatively nonspecific symptoms. Fever is a hallmark feature that is present in most cases. It is often associated with other constitutional symptoms such as chills, malaise, night sweats, and weight loss. Many patients also develop a new or changing heart murmur due to impaired closure of heart valves from the vegetations, resulting in valvular regurgitation. Murmurs can be systolic or diastolic depending on the valves affected. In severe cases, there can be critical disruption of valvular function, manifesting as heart failure. Extension of the infection into surrounding tissue may also lead to paravalvular abscess, which can result in conduction abnormalities such as heart block. Because the valvular vegetations are friable and easily disrupted, embolic phenomena are common in patients with infective endocarditis. The emboli shed from vegetations contain viable bacteria, so they are referred to as septic emboli. Characteristic cutaneous manifestations occur due to microemboli lodging within the dermis and include petechiae, Janeway lesions, and splinter hemorrhages. Janeway lesions are non-tender erythematous macules located on the palms and soles, characterized by microabscess formation. Splinter hemorrhages are reddish-brown hemorrhagic streaks beneath the nail bed that result from rupture of longitudinally oriented nail plate capillaries. Septic emboli arising from the left heart can also result in infarction of the brain, spleen, kidneys, and other organs, causing a wide variety of clinical sequelae. In contrast, vegetations affecting tricuspid or pulmonary valves primarily result in septic pulmonary emboli, which can be an important finding indicative of right-sided endocarditis. On imaging, septic pulmonary emboli appear as multiple bilateral nodules with variable degrees of central cavitation found predominantly in the peripheral lung regions. Infective endocarditis also predisposes to characteristic immunologic phenomena. The generation of antibodies against circulating bacteria leads to subsequent formation of immune complexes that deposit in various organs, causing small vessel vasculitis. Specific manifestations include Osler nodes, Roth spots, and glomerulonephritis. Osler nodes are tender, subcutaneous purple nodules usually found on the distal pads of the fingers and toes, while Roth spots are retinal hemorrhages with small pale centers. Infective endocarditis can lead to significant morbidity and mortality if not promptly recognized and treated. Early diagnosis and appropriate management are crucial for improving outcomes and reducing mortality. The diagnosis of infective endocarditis requires a systematic approach combining clinical assessment, laboratory testing, and imaging studies. A thorough history should be obtained, including risk factors for endocarditis, such as pre-existing valvular disease, intravenous drug use, and recent dental procedures. Physical examination may reveal classic signs, including heart murmurs and peripheral skin findings. Blood cultures are essential for identifying the causative organism. 2 to 3 sets drawn from different venipuncture sites should be collected before antibiotic administration to increase sensitivity. Echocardiography is also performed to detect vegetations and assess valvular and overall cardiac function. Transthoracic echocardiography is usually the initial test performed, but is limited in sensitivity and image detail. Transesophageal echocardiography is more invasive, but provides better visualization of cardiac structures. A vegetation typically appears as an irregular echogenic mass attached to a valve component that oscillates with motion of the valve. After performing a thorough assessment, variations of the Duke criteria are often used to aid in the diagnosis of infective endocarditis. These consist of major and minor criteria, with diagnosis requiring the presence of certain combinations of these criteria. Minor criteria are features supportive of the diagnosis, including the presence of characteristic risk factors and physical examination findings. Major criteria include more definitive evidence, such as blood cultures growing typical organisms and identification of vegetations on imaging. Infective endocarditis is treated with intravenous antibiotics. Acutely ill patients are urgently started on empiric antibiotics that have a broad spectrum of activity against gram-positive organisms. In stable patients with a more indolent course, antibiotics are often withheld until the results of blood cultures are available to target therapy toward microbial susceptibilities. Antibiotic therapy is typically continued for 4 to 6 weeks. Surgical intervention to remove damaged heart valves or other cardiac tissue is another component of treatment. Surgery is frequently indicated in patients who don't respond appropriately to antibiotics or those that develop complications such as heart failure or intracardiac abscess. Patients with prosthetic valves or fungal endocarditis are particularly likely to require surgical intervention. Because of the seriousness of infective endocarditis, antibiotic prophylaxis is given to reduce the risk of infection in high-risk patients who are undergoing invasive procedures likely to result in bacteremia. To sum up, here are the key points to remember. Infective endocarditis is an infection of the endocardium that usually involves one or more heart valves. The pathogenesis involves damage to the endocardial lining, which promotes adherence of a platelet fibrinolysis that becomes secondarily infected during periods of bacteremia. As the bacteria proliferate, the resulting vegetations can lead to valve destruction and embolic complications. Risk factors for infective endocarditis include pre-existing structural heart disease, poor dentition or dental infection, intravenous drug use, and prosthetic heart valves. The most commonly implicated organisms include gram-positive bacteria, especially Staphylococcus aureus, viridans group Streptococci, Enterococci, and coagulase-negative Staphylococci. Most patients present with fever, constitutional symptoms, and a new or changing heart murmur. Other characteristic features include embolic and immunologic phenomena such as Janeway lesions, splinter hemorrhages, Osler nodes, and Roth spots. Septic emboli can also result in infarction of the brain, spleen, kidneys, and other organs. Septic pulmonary emboli are a distinctive finding of right-sided endocarditis. Blood cultures and echocardiography are crucial for diagnosis, which is often aided by application of the Duke criteria. Treatment includes 4 to 6 weeks of antibiotics tailored to culture results, with surgical intervention in select cases.